Hey everyone, my name is Fatima, and in this video, I'll be talking about the pathological content of the pleural cavity. So, the pathological content itself can be air or fluid. If it's air, we call that as pneumothorax, and if there is some abnormal accumulation of fluid, it's generally termed as pleural effusions. To be specific, if there is blood in the pleural cavity, we call that as hemothorax. If there's pus, it's pyothorax, and if there's lymph, it's known as cavithorax. Starting with pneumothorax, pneumothorax is characterized by the presence of air within the pleural cavity, leading to either a complete or partial collapse of the lung. It can be classified according to etiology, in which case it's divided into spontaneous and traumatic pneumothorax. Spontaneous itself is further divided into primary if there is no underlying lung disease, secondary if there is some underlying lung disease, for example, COPD, and recurrent pneumothorax. Traumatic could be because of some penetrating injury or iatrogenic trauma. If it's classified according to the description of the puncture wound, we have open, closed, and tension pneumothorax. Open if the puncture is through the chest wall, closed if the chest wall remains intact, and tension if there is a one-way valve that has been formed, allowing air to enter the pleural cavity but not really to escape out of it. So here we have the diagrams of the open and closed pneumothorax. You can see here the lesion is through the chest wall and the air can freely enter from outside into the pleural cavity. Here the chest wall remains intact, but when you inspire, the air can enter into the lung and through the lesion basically into the pleural cavity. In the case of tension pneumothorax, you can see that when you inspire, air is basically entering the lung and through the lesion into the pleural cavity, as seen here. But when you finally expire, the valve kind of closes and it doesn't allow the air to basically go back to where it came from. So you have progressively increasing pressure here in the pleural cavity, which can compress the adjacent structures. The clinical features include sudden, severe, or stabbing ipsilateral pleuritic chest pain and dyspnea, reduced absent breath sounds, reduced chest expansion on the ipsilateral side. There could be some subcutaneous emphysema, respiratory distress, and cyanosis. You could have distended neck veins and hemodynamic instability, for example, tachycardia, hypertension, pulsus paradoxus. There can be some secondary injuries also present, for example, open or closed wounds. In the case of tension pneumothorax, you see tachycardia, hypertension, a rapid decrease in SpO2, and increased ventilation pressure. The complications can include respiratory or cardiac failure, hemodynamic shock, recurrence. For example, in primary spontaneous pneumothorax, the recurrence rate is 50% in the first 2 years. There could be pneumomediastinum or some pneumoperitoneum as well. Treatment, you can do needle thoracostomy, which is an emergency procedure that's usually done in tension pneumothorax. So the position where you do it is in adults. It could be in the second intercostal space in the mid-clavicular line, or the fourth or fifth intercostal space in the mid-axillary or anterior axillary line. This is typically followed by the insertion of a chest tube. In children, you normally place it in the second intercostal space at the mid-clavicular line. The chest tube is basically placed in the fourth or fifth intercostal space between the anterior and mid-axillary line, and it's connected to a chest drainage system, which can be with or without suction. And this drains the air or fluid that's accumulating in the pleural cavity. And chest X-ray is always performed after the procedure is complete. Pleural effusions are basically accumulation of fluid within the pleural space, and this could be because of increased hydrostatic pressure, decreased oncotic pressure, increased capillary permeability, or decreased lymphatic drainage. It can be divided into transitive and exudative pleural effusions. In the case of transitive pleural effusions, the fluid has a low protein content and low number of cells. This occurs usually due to increased hydrostatic pressure or low plasma oncotic pressure, for example, in heart failure, cirrhosis, or nephrotic syndrome. In the case of exudative pleural effusions, you have the fluid has a high protein content and the content of inflammatory cells is also increased. This is usually due to some inflammation and increased capillary permeability, which could be, for example, in pneumonia and some other infections. Normally, up to 15 milliliters of serous fluid is found in the pleural cavity. So, classifying the type of fluid that you would find in the pleural effusion itself, if there's blood, it's known as hemothorax, and this could be because of some trauma, rupture of an aortic aneurysm. If there is transitive fluid, it's known as hydrothorax, and this fluid is basically passively pushed from the vessels of the pleura into the pleural cavity, for example, in heart failure. Pyothorax or empyema is the term given to the accumulation of pus within the pleural cavity, for example, in pneumonia. Chylothorax is the accumulation of lymphatic fluid from the thoracic duct into the pleural cavity. This has a milky or turbid appearance because of the presence of chylomicrons, and it's usually because of trauma or malignancy, for example, lymphomas. Pseudochylothorax is differentiated from chylothorax because here the fluid has a high content of cholesterol and low triglyceride level, and it's usually because of some chronic inflammation in the pleural cavity. It could be because of tuberculosis as well. The clinical features include dyspnea, symptoms of hypoxia, pleuritic chest pain, dry non-protective cough, and obviously some symptoms of the underlying disease, for example, fever and empyema, cachexia if there is tumors, symptoms of left-sided heart failure as well. But if the pleural effusion is small, it can be asymptomatic. On the physical exam, you would see dullness to percussion on the area of effusion, reduced tactile fremitus, and on auscultation, you would hear the pleural friction rub, as well as either absent or faint breath sounds. The diagnosis is made by chest X-ray, ultrasound, as well as diagnostic thoracocentesis. This is basically a procedure in which you insert a needle into the pleural space and drain the pleural effusion. And the position of is basically guided by ultrasound, and this is done for symptom relief, for example, to relieve dyspnea, as well as for fluid analysis for the diagnosis of the underlying cause. Here are the references that I used, and with that, we come to the end of this video.